a really and then many different faculty, and we haven't historically had a good venue to bring multidisciplinary faculty together into the same room to kind of hear about what everybody's doing. So a group of us, including Danielle Lung from 3I, have worked to kind of try to have a monthly meeting with lunch to stimulate collaboration and learn from all of our fantastic colleagues. So I'm not going to introduce our three superstar colleagues here who are going to talk about their work today, but I'm so glad that they're all here on faculty. We're so lucky to have them. So I'll turn it over.
Steve, you're going to introduce yourself first. So
okay.
Go ahead.
Good afternoon, everyone. My name is Stephen Kimani. Excuse my voice, I'm still recovering from a cold, so I hope you can hear me okay. I'm currently an attending physician in the Department of Medicine, focusing in breast. I've been at the U for about 3 years, or 3.5 years now. And prior to coming to the U, this is sort of my background. So I have a convoluted journey, and I'll just keep it brief. So I'm originally from Kenya, where I did the bulk of my undergraduate and medical training. Did get exposure to the United States as a visiting exchange student, again, in my fourth year of med school, having rotations at UC Davis. And then I first met Melissa in Durham, North Carolina, when I came to do a master's in global health studies. This was back in 2012, so that's about 12 years now. During my master's in global health studies, I'd always kind of envisioned a path as an investigator in epidemiology and in population health. But I did realize that I also had an ongoing concern for clinical care for patients. So I transitioned back into clinical medicine, completing a residency at Duke in internal medicine and a fellowship in hematology at UNC in Chapel Hill. During my fellowship at UNC, I took a year to focus dedicated path in global oncology, where I spent most of my time, my research year fellowship in Malawi. And then I moved to Utah 3 years ago as a part of the faculty here. And then I'll hand over to Melissa.
Yeah, thanks. Well, one of the things that we hope to really highlight here is this interdisciplinary collaboration and the partnerships we've formed with each other and with our partners overseas. So I have my training. I was an undergrad at UNC Chapel Hill. I have my master's in gender and international development from the University of Sussex in the UK, and then did my PhD back at UNC in public health. I was at Duke at the Global Health Institute as my first academic appointment, starting in 2008, and that's where I had the pleasure of getting to know Steve. Steve was actually the first master's student that I mentored, and we spent some time together in South Africa, had several publications together, but also became really good friends. And so that has continued. I also, Gita will tell you, she was also at Duke at the Global Health Institute. So Gita and I also got to be very good friends. Gita is probably the one who introduced me to the field of oncology and bringing me on board some studies looking at the intersection between HIV and cancer, which she'll tell you all about. And then I moved here to the University of Utah in 2020, and my appointment is in the Department of Population Health Sciences in the School of Medicine. My research is largely in the field of stigmatizing health conditions. I've been funded by multiple NIH institutes looking at stigma in the context of obstetric fistula, sexual trauma, substance use, HIV, and most recently cancer. And it's been really great to kind of be taking this topic and looking at different health conditions and different settings and looking at those similarities and differences. And it's been really wonderful to kind of be expanding into this new area of cancer-related stigma.
So it's so great to be here and see so many of you in person, and thanks to everyone who's on the Zoom. So I Yes, we all have a North Carolina connection. But before that, I was at I did medical school at Brown University, and there I got a strong foundation in social justice and medicine as a tool for social justice. And I think that sort of laid a foundation for the work that I have done throughout the rest of my career. I did my residency in radiation oncology at the University of Pennsylvania. And during my time there was a primary care partnership in Botswana, but there was very limited cancer care infrastructure, and there was no partnership between the institutions. And so when I was there, we did sort of a needs assessment that got that partnership going and off the ground. And now it is a lot more robust. I did a master's in health policy research at the University of Pennsylvania, and then came out here to Utah. So here I'm in the Department of Radiation Oncology. I'm a physician scientist, and I'm also Senior Director of Programs to Enhance Diversity at Huntsman Cancer Institute. I like to joke around that Melissa and I were like co-recruited here. We were like a couples recruit to University of Utah because we came here at the same time. And the other thing so Melissa mentioned, I got my start in HIV malignancies, really coming more from like the health equity perspective. And we've seen big disparities in the population of patients who have both HIV and cancer. And so some of the work that we did demonstrating that inequity and then trying to understand drivers of it led to the development of the National Comprehensive Cancer Network guidelines for cancer in people with HIV and Kaposi sarcoma. So I co-chair those. Steve Kimani is also on our guidelines panel. And so these are clinical guidelines informed by a lot of the research that's being done in the space. And then I've got some funding from NCI looking at cancer treatment disparities. That was my KO8. And then looking at some molecular features of cancers in people living with HIV. All right. So I'm going to turn it over to Steve.
All right. So we've tried to structure this talk into 3 parts. And in the way we're going to approach this, I'm going to talk briefly about the field of global oncology because the essence of our talk is looking at cancer and stigma in Malawi. And I'll try to highlight my experience with our research partners at Kamuzu Central Hospital. Melissa will dig deeper into cancer-related stigma and talk about specific findings from some of our work. And then Gita is going to tie it all together in our upcoming investigation. So academic oncology as a field is been a quickly evolving discipline. It's relatively new, and I think while the practice of global oncology is not new, the path towards formalizing academic so, and this has been under the stewardship of several key stakeholders in the field of oncology. So ASCO, which is our national membership organization, has been at the forefront of forming this partnership. And NCI is at the center of everything. So this kind of begins in 2011 with the initial identification of the need to establish global oncology leadership programs. But I want to highlight specifics, kind of landmark things that happened. Let me see. Well, so the gist here is the establishment of the Global Oncology Task Force in 2017-2018 really helped catapult training of oncologists who are focusing in low resource settings. And this was mostly instigated through the ASCO Global YIA pathway. So this is a young investigator funding mechanism, supported some of the fellows or junior partners, both US and international partners who are looking at doing cancer-related research internationally. And one of the bottlenecks in terms of formalizing academic oncology as a training discipline for fellows was the ACGME requirement for supervision of. And up to that point, most fellows who are trying to do global oncology will have to extend their fellowship training to accommodate for significant time that they have to spend in areas where their research is happening and where they need to make the impact. And so that was not, that someone could understand why that was not appealing to people. And so ACGME, as one of the silver linings of the pandemic, is that that era of the pandemic and remote supervision helped clarify that it's possible to do remote supervision as long as there are clear guidelines and there are clear curriculum, and fellows can spend time abroad and still count towards their clinical time requirement in the United States for board certification. So that led to 2020 ASCO changing their standard educational format to include almost each topic will have a section on global oncology or perspectives on cancer. And in 2023, there's been an establishment of a formal curriculum in global oncology. So I think all this development has mostly been driven by the background awareness that while there's a rising incidence and prevalence of cancer across the world, and that while outcomes have improved for certain cancers in high resource settings, and survival is getting better, and we're starting to bend some of the most prevalent cancers in the high income settings, the bulk of the projected burden in future will be in low resource settings where mortality is still pretty high and survival outcomes are dismal. So it's important to, when you think about looking at the world with an equity lens, it's important to not forget that most of the deaths that are going to be coming from cancer are going to be happening in some of our most impoverished parts of the world. And Africa is one example where you can look at the number of cases, about 1 million a year, and the number of deaths almost equal to that. So survival for cancer remains poor in those settings. And when you look at this map here, which looks at the mortality to incidence ratio of cancer, meaning if you're diagnosed with how many people are dying from that disease in relation to how many new cases there are. So the darker colors are showing that the mortality to incidence ratio is greater than 0.5. And you can see that those are concentrated in the sub-Saharan Africa and Southeast Asia, while the green, which are low mortality to incidence ratio, are in the high. And this on the right-hand side, you look at the human, and these are countries that are still far behind in the economic development platform. This is just a striking and unacceptable degree of cancer inequity in this modern age. And this is kind of the perspective that my life experiences as a Kenyan-born physician with strong ties to the African sub-Saharan context. We do think of survival in some of the low resource settings as everything is bad. Nothing good happens there, but that's not necessarily true. While the burden is projected to increase and the mortality is still behind that of high income settings, there's been significant improvements, even through my lifetime, where when I was going through med school, this is in the early 2000s, in Kenya, the only place you could receive cancer treatment was in the medical school where I went to train. And the only cancer treatment available was for radiation therapy. There was a cobalt machine that was broken pretty much for 5 years while I was there. So you're lucky if you got any radiation with the cobalt machine. Chemotherapy was not available, and absolutely there was no oncology as a field of training. In fact, during my medical experience, the only form of oncology exposure I got was through hospice, hospice training. Now you go to Kenya right now, and there are cyclotron machines. There's enough development in cancer treatment landscape. Most of it is in the private sector, but a good chunk of it is also in the public sector. That is just one example, and it's an anecdote. But what that is meant to demonstrate is that there's been modest improvement in survival. And it's important to not forget that if you're going to invest in curing patients, you need to invest in supporting these patients beyond their cancer diagnosis. And so that brings me to Malawi, which is, historically, Malawi has been thought to be one of the poorest countries in the world. That's not true anymore. Again, as a testament of the rapid progress that's happening in the sub-Saharan context. But it's still relatively impoverished, and it's a landlocked country in the southern part of the continent. It has a large population, mostly rural. And Kamuzu Central Hospital is a public health facility that is able to provide treatments. At the time when I was a fellow there in 2019, there was no existing in-country oncology training program. There were 2 oncologists for a population of about 11 million. And there was 1 hematologist in the public hospital. So as a fellow in Hem and Onc, I served as the second hematologist, and I'll get consults from all over the country. But so based on history of global health research in Malawi, which was mostly driven by the need for, infectious disease colleagues back in the late 90s, early 2000s, there's been a robust, they've been able to build a robust research infrastructure, particularly looking at infectious disease. So in 2014, through partnership between the Ministry of Health, the UNC Chapel Hill, and the University of Malawi College of Medicine, Malawi Cancer Consortium was established as a mechanism to be able to coordinate research looking at non-communicable diseases as well as communicable diseases, with a particular focus on building up the cancer research and treatment infrastructure in Malawi. So as of this talk today, the Malawi Cancer Consortium has expanded beyond just infectious disease, which still remains a big component of that consortium because of the higher prevalence of infection-associated cancers in the region. But we have maternal and child health, which has come on board. We have cancer, which is growing. And now there's also global surgery programs that is part of the Malawi Cancer Consortium. A key focus of that consortium has been select highly prevalent cancers, lymphoma, breast cancer, cervical cancer, and Kaposi sarcoma, the big ones, and then pediatric cancer and esophageal cancer. So this used to be the clinic when I was there in 2019. It was kind of hole in the wall in the corner of the public hospital. We just didn't have any room to even give infusions. So we'll often give IV hydration while patients are waiting in the hallway. We'll have one room where we'll examine patients, but also inject chemotherapy. But again, as a testament to what investment is doing in the continent, and this is not philanthropy, this is researchers and clinicians and patient advocates and governments coming together to prioritize cancer care. They built a new cancer hospital in 2020, and when Melissa and I were there in 2023, this cancer center was opened. I'll talk briefly about the KCH cancer cohort studies that are going to be the basis of our patient population here. There are several patient cancer cohort studies. There are 2 main ones that I closely worked on, and this will serve as model for post-treatment research or post-treatment clinical care of cancer survivors. So lymphoma, as we know, is pretty common. Most lymphomas can be connected to AIDS and HIV, but others might not. Breast cancer is also quite prevalent. And there are these well-established cohorts that represent some of the best characterized groups of cancer patients in the continent, meaning from proper diagnostics, at least standard first-line treatment or acceptable first-line treatment, and reliable data on survivorship. And what I want to demonstrate in this slide is that when this initial cohort was established in 2013 by Satish Gopal, at that time, the standard treatment for aggressive lymphoma was CHOP chemotherapy. This is not the standard treatment in high-income settings. And average survival was about 2-year survival was about 42%. Satish was able to make a case to upgrade treatment by adding the rituximab chemotherapy, the rituximab agent, and that has been shown to improve survival from 42% to 55% with just one intervention. That is also cost effective, and we can show data about cost effectiveness. But this takes people who work in the continent and people who understand the problems and the priorities to make these investments and then make the case for policy stakeholders to adjust. So right now in Malawi, the National Health Insurance Plan is able to cover rituximab because a context-specific evidence supports its effectiveness and cost savings. Breast cancer is lagging behind, and unfortunately, most breast cancer being diagnosed in the continent, and Malawi is an example, is diagnosed with symptoms. So it's almost no stage 1 diagnosis. A few stage 2, majority are stage 3 or stage 4, meaning highly advanced or metastatic and non-curable. And these are young women. And so there is a role for, there's more that can be done to improve that. So when I started as a fellow, I looked at these cohort studies and I was like, we've already, over the 10 years between 2013 and 2019, close to 10 years, we have improved survival for some of these common cases. But I was wondering what happens to patients after that? Do we just treat their cancer and they suddenly go back to their life, or what are their concerns at that point? So I sought to leverage existing cohort studies to advance patient-oriented research, looking particularly at cancer survivorship. And my Fogarty Global Health Fellowship program looked at getting the voices of cancer survivors about their treatment experiences, and with the long-term goal of identifying unmet area of needs and helping to build supportive programs to complement the investments that have been done in diagnostic and curative treatments. And so this was a mixed method study looking at qualitative data and quantitative data. One of the aims we sought to look at was what some of the barriers could be. So these were cancer survivors from the breast and the lymphoma cohorts who had successfully been diagnosed, treated, and had achieved remission. And we looked at asking them about what were the barriers they faced in their journey. And we see there were significant barriers across diagnosis, treatment, and other parts of the continuum. And some themes were emerging consistently, including misdiagnosis, ineffective referral system, stigma, which is a big one and a big focus of our talk today, but also competing priorities and financial toxicity. And so as we try to narrow specifically and look at stigma today, I'm going to pass off to this talk to Melissa, who's going to tell us more about our findings relating to stigma.
Thank you, Steve. And this work is really built on the partnership that Steve has developed at Kamuzu Central Hospital over years. And when I went to Kamuzu with Steve, it was just really clear how valued he was from his time that he spent there. And I think it speaks to the importance of prolonged time with partners in their setting to understand the barriers, how things get done, developing partnerships, et cetera. So just to begin thinking about what stigma is, I really want to make sure we frame stigma as a social construct. And so stigma is about an attribute that is socially discrediting. So what that means is that it really depends on the social context and how something is experienced and perceived. And stigma changes across time and across space. And so we can think about sort of, the areas in which we have studied stigma. I think HIV is the one in which we have had the most research done in terms of stigma. And you think about sort of the stigma that comes as it relates to HIV really has to do with populations impacted, a sense of blame placed on patient behavior, as well as the treatment options, the prevention options that are available, the treatment options that are available. And we've even seen this change considerably over time. And I know Gita from her work has seen sort of HIV stigma change over time. I certainly have in Africa as treatment has become more available. So you consider cancer, for example. I've told people I work on cancer-related stigma, and they're like really surprised because there's like, why is there stigma related to cancer? And I think at this point in time here in the U.S., I think we're at a very different place. But you think back to the 1940s, 1950s, like, what did it mean at that point if you were diagnosed with cancer? What was the patient experienced? How was that perceived? And what were the things going on in terms of the social context at the time, where there might have been shame, some blame, some silence, some fear, et and you see that now in places where you really don't have the resources to support cancer care. So in the US, we have a really large survivorship community. It's a vocal survivorship community. All of us know people who have lived with cancer and thrived with cancer, and we have ribbons and we have runs and we have people talking about their experiences. But in Malawi, for example, there's not the survivorship narrative that exists at a population level like we have here. What Steve was saying about breast cancer, most people are diagnosed with breast cancer when they become symptomatic. They're not routine mammographies. So you have already disfigurement. There is a shame because you don't know where it came from. You have never talked to anyone with breast cancer. There's this real feeling of isolation, secrecy, et cetera. So understanding kind of stigma in its social context is really important. And I think we can only hope that as resources become more available, that stigma is also going to change. And at the same time, there's a lot of work to be done, of course, around community knowledge, community engagement. So we care about stigma because it really impacts across the whole cancer continuum. Early detection, we know from HIV, for example, it was really challenging to get people motivated to go get an HIV test if there was not treatment available, or if that would result in sort of, having this very stigmatizing label. There are a lot of now much easier to get people to get treated if there is a test and treat modality, that there's testing you can immediately get access to. It impacts your ability then, when there is treatment available, to stay in treatment, to attend appointments, because you may not have the social support you need, the community. You may not want to disclose your cancer status, and so you may not want to be going to care, and then following through on your care, your follow-up, and then of course into your end of life care. So treatment as this, stigma as this social construct really has an impact across the whole care continuum. So if we're thinking about clinical outcomes, if we're thinking about well-being outcomes and quality of life, we really need to be paying attention to the idea of stigma. So when Steve came here, we, of course, we're looking at opportunities for collaboration. And Steve brought all of this qualitative data that he had collected when he was in Malawi as part of this longitudinal study on quality of life. And he, in sort of looking at this data, and I sort of helped, I brought some undergraduate students. I don't think we have any of our undergrads here in the room, although well, Olivia is when she was right after undergrad was involved in this. But I sort of began some of the qualitative analysis, and it was really clear that like stigma, as Steve said, was coming out as this barrier across the care continuum. So we decided to delve into that more, and Steve and Gita and I and others wrote this paper that was published in JCO Global Oncology about cancer-related stigma in Malawi, and it's gotten a lot of coverage in part because there aren't many papers like this that are really taking this in-depth, nuanced approach at cancer-related stigma from the perspective of cancer survivors. So what we were trying to answer in this paper is sort of three questions. We wanted to know what's driving stigma, what does it look like, and what impacts is it having? So the drivers that we identified are beliefs about cancer origin, that cancer is infectious or due to bewitchment, or for many of that, it's a marker of HIV. And so HIV is highly prevalent in Malawi. And so it was seen as sort of something that people may assume that you have HIV if you have, for example, wasting due to cancer, changes in disfigurement or other things. The changes themselves due to cancer drove stigma, physical changes, as well as the loss of your social or economic role, that you're not able to make the same contributions. And then very importantly, expectations of a future, and cancer seen as a death sentence. And I think that speaks to the absence of really having a community of survivors. The manifestations, meaning what did stigma look like? People talked about gossip, humiliation, feeling isolated, and courtesy stigma towards family members. So in other words, children being treated differently because their mother had cancer, or spouses being treated differently. And the impacts, not surprisingly, mental health distress for the patient, impediments to care engagement, lack of cancer disclosure, which also meant not getting support as regards to the cancer care, and self-isolation. So people isolating themselves, which is related, of course, to disclosure as well. So that work that we did also pointed to some intervention needs, and these were sort of from the perspective of cancer survivors and patients. So they talked about the need for really robust counseling and health facilities, that cancer-related stigma needs to be addressed more forthrightly, and they needed to help both support patients, but also give patients strategies to help them deal with cancer-related stigma. Peer support was really important. Many people talked about, well, once I ended up at Kamuzu Central Hospital and saw people like me, my whole outlook changed. Or once I had conversations with people who had gone through the same process, it really gave me hope for the future. And many of them also said at the end, we said, do you have anything else to add? They said, call me if you need me to talk to other patients. I'm ready, I'm willing. And then finally, community education, of being able to educate community more broadly about cancer. So we thought we need to sort of develop some interventions to address this, but what we knew is that if we want to be able to address cancer stigma, we need to be able to measure it. And so one of the things we did is we looked out in the literature and we said, what exists in terms of really validated cancer stigma scales that can be used across populations and agnostic of cancer type. And what we found is that was really lacking, that there was not a robust measure that could be used for cancer-related stigma. There were some scales that had been developed in US settings, that maybe there was a lung cancer stigma scale. There were some other things that we just thought nothing really resonated for the population that we were working in. So we applied for a supplement to the NIH. So NIH supplements are for funded grants. You're able to apply for a supplement to do some additional work. And these are typically time limited to about a year. The budget is relatively small. And they're really meant to kind of accelerate or build on the existing infrastructure of research to accelerate a new research idea. So we applied for this call to strengthen global cancer health disparities research, and we proposed to develop a measure of cancer stigma for global use. And the methods of this, we used psychometric methods, so that's the methods of scale development. So we identified an item pool. A lot of that was pooling on HIV stigma scales that existed and scales related to other types of stigma or generic stigma. We then took that item pool and we talked with oncology providers in both the US and in Malawi to try to get feedback on the content validity of that tool. We then shared the tool in what we call cognitive interviews with cancer patients in both Malawi and Utah to look at face validity. And throughout this, we're discussing as a team and we're making changes. And then once we had a pretty robust item pool that we were happy with, we administered this to 200 cancer patients, 100 in each site. And then we worked with a statistician in the SDBC to do some psychometric analysis to determine the final scale items. So we're working on the publication now. We hope it's going to come out pretty soon or be submitted pretty soon, and that it will really make a contribution to the literature in terms of being able to measure so that we can look at differences in cancer stigma across populations, so that we can look at how cancer-related stigma impacts outcomes, and we can track it over time to see if what we hope is that as treatment becomes more available, cancer-related stigma decreases. So this is briefly, the scale is in 3 domains. So these are all administered at the level of the patient. So these are statements for the patient to then respond to. Enacted stigma is the stigma you've experienced. Anticipated stigma is the stigma that you fear from others when they hear about your cancer. And then internalized stigma is shame and how you feel about yourself. So I'm going to pass it on now to Gita to talk about where we're going next.
Okay, great. So you have heard about cancer and cancer stigma. And Melissa talked a little bit about HIV and HIV stigma. So the question now is, how do these two intersect? For the population of people that have both HIV and cancer, how do we think about stigma and conceptualize stigma in this population? So the NCI recently put out this NOFO for applications that are looking at the confluence of cancer stigma and HIV stigma. And there's an R01 mechanism as well as an R21 mechanism. And one of the really, I have to say this is like a career highlight, because I think in academia, we measure our impact in these very, in very specific ways, right? So those of you that are just starting your academic journey, we look at publications, we look at grants, we look at this, these very specific things. And when we delved into this, we knew this NOFO was coming. When we opened it up and read it, we saw that our work was cited as justification for the entire call. And thank you. This isn't something that you necessarily put on your CV, but I think it's a measure of impact. And so I would just encourage you to find the ways that you're having an impact that aren't necessarily measurable, because at the end of the day, was it Albert Einstein who said, not everything that counts can be counted, right? So we want to make sure we're keeping our eye on that. So the rationale for this is basically this idea that the experience of living with both HIV and cancer is different from the experience of living with HIV or cancer. And lucky for us, we had written this paper that was cited is a editorial talking about intersectional stigma of Kaposi sarcoma and HIV. So we know that stigma impacts different populations in different ways, right? And there are multiple stigmatizing identities, demographic characteristics, populations. And so how do they come together and intersect? And how do we better understand that? So Kaposi sarcoma is a really unique form of cancer. So Steve talked a lot about global cancer incidence and cancer incidence in Malawi. And you may remember he showed you that KS is one of the most common cancers in people living with HIV, particularly in Eastern and Central Africa. In Malawi, KS accounts for almost a fifth of all new cancer cases. And this is a disease that carries substantial psychosocial burden because it is visible. This is an image from a patient in Malawi who gave permission to use the image, but you can see, let's see, I'll use this pointer here. The lesions are violaceous, they're purple, they're raised, they tend to occur on the extremities, on the face. They're very visible, and they are seen as a marker of HIV and often AIDS, which is end stage HIV. Although the prognosis has improved with effective antiviral therapy and cancer therapies, we know that the majority of cases of KS cases that occur in sub-Saharan Africa present with advanced disease. And those presenting with advanced disease require chemotherapy. And of course, chemotherapy carries substantial toxicity. So fatigue, hair loss, again, markers of being ill, loss of appetite, and financial toxicity. This was another area that is reported to be a significant burden for patients both in the US and in global settings. We know that the impact of toxicity is significant. So in this paper that was published from this group in Malawi, they found very high rates of treatment discontinuation. So about 43% of patients with KS in this cohort discontinued early. 10% had treatment delays. And of course, no surprise, delays and discontinuation lead to elevated mortality. And you can see here, this is age standardized mortality rates from Kaposi sarcoma. This is from 2020, but the deepest red is the highest mortality. And again, you can see this is concentrated in East, Central, and Southern Africa. So to try to understand, a lot of the work we've done with the US HIV population, at those that have HIV and cancer, people always say, well, how do you know that what you're seeing is the impact of HIV and not the impact of these other sociodemographic characteristics? And so isolating the impact of intersectional stigma is a challenge. We did this study at Duke where we interviewed 27 people with HIV and cancer. There were 3 groups of patients that had had completed their treatment successfully, were actively under treatment, and those who had discontinued their treatment due to treatment challenges. And what you can see is that among the barriers to cancer care, the most significant was side effects from treatment. The second most significant was stigma. And so people describe this experience of having lived with HIV, processed their HIV diagnosis, they go into a different care setting and they are re-stigmatized all over again. And it was really like the comments made me pause going through this qualitative data. And just, when we see people who come through the door, for us, it's, we see one patient after another and we see a lot of the same cancers. And it just was a reminder that people come in a context and they bring with them, the context of having HIV in this case. And you can see this quote from one of the patients in the study. It made me feel like, seriously, what next? You have a devastating disease as HIV. You're living with that and you're doing okay. And then later down the line, you're diagnosed with cancer. Now you've got 2 deadly diagnoses. Dealing with both is a double bullet. So this patient encapsulated this concept really well. So, we know that peer support is really impactful. And you saw that from the work that Melissa shared with you. We also know that patient navigation is really important and really successful. And these are both in HIV and cancer context. So they're slightly different, right? Peer support is those who have the same diagnosis as you. They've walked the same journey you have. They can provide anecdotal experience and support. Patient navigation is somebody who has knowledge of the healthcare context, and they can help you actually navigate from one step to the next of that cancer care continuum that Melissa showed. And we know that interventions have been studied separately for HIV and cancer, and they've been shown to increase care engagement, mitigate disparities, reduce stigma, improve measures of distress and well-being, improve care coordination, and decrease hospitalizations. What we're trying to do now is bridge the gap. So we're trying to bridge the gap between peer support and patient navigation, and we're trying to bridge the support between HIV interventions and cancer interventions. And so this is a schematic of the work that we're going to propose for the R01, the NOFO that I showed you. So we would like to do a peer navigation intervention. So we'll be using navigators who are actually peers, who have experienced KS, who are people living with HIV. And the idea is that peer navigation would combine the strengths of patient navigation and peer support. And this would result in looking at different measures of cancer outcomes, improved measures of cancer outcomes, improved measures of HIV outcomes. And the global goal is to improve outcomes and reduce disparities in this population. So we are planning to propose, we would like to propose to develop a peer navigation intervention. We're going to look at stigma reduction as a component of that based on our preliminary work. We're going to look at navigation as a component of that. And then we'll look at several mediators and moderators of that stigma. And then our outcomes in this type 1 hybrid efficacy implementation design are going to be cancer care engagement, HIV care engagement, and then we will secondarily look at implementation outcomes. And as I said before, we're hoping that this will improve quality of life and survival with people with HIV and KS. So I hope we've kind of shown you how we have worked together for a long time. We're from different disciplines. We have different strengths, different areas, different collaborative networks, but we've been able to kind of put together all of our areas of expertise to focus in on this specific area and hopefully have an impact. I just wanted to say that it's such an incredible honor to work with Melissa and Steve. They are phenomenal colleagues, phenomenal collaborators, but even more importantly, they are such outstanding friends, and they're friends who have become family. And so it's just like, if you can find this in your career, just grab it, cherish it, hold on to it, because it is like the cornerstone for me, and it gives me a lot. It helps me move forward because I have such a supportive and amazing community. Steve is moving to UNC, and although we are going to continue this collaborative work, I just wanted to take this opportunity to let Steve know how much we love and appreciate him, how much we respect him, and that the door is always open if he wants to come back to the University of Utah. And lastly, I just want to thank all of our collaborators. There's a whole team of people, funders, a staff in all of our labs that have contributed to this work. And of course, most importantly, the patients who participate in the study, doing work that is from the community, that's not just community engaged, but comes directly from the needs of the community, is so important. And I think that paired with this idea of sustainable science and intervention is something that's really important to all of us as a study team. So we're really happy to share this with you. And I think now, do you guys want to come up, and we're happy to take any questions if we have time.
Real important question is, why, Steve, are you removing away? That's a real problem. So question, you mentioned survival, hope for survival. What kind of information and what causes this kind of work then to lead to hopefully improve survival? What information do we have, and what do we think will really make that happen?
That's a great question. So some of the cancer outcomes that we're looking at are things like completion of treatment toxicity, follow-up, and survivorship. And those each individually have been shown to be to impact survival. So those are the kinds of things that we're hoping reducing stigma, improving peer support and peer navigation will help people actually complete the treatment that we know impacts their survival and reduce toxicity and improve quality of life.
And I have another question. Have you looked at, not just from, I saw, some of the interviews with the medical people, but that seemed like it was geared towards looking at the perception from the patient's perspective. We're finding in Ghana that, sometimes the healthcare providers are teaching a lot of the wrong things that lead to the stigma, and trying to change the thought process of those that are actually the physicians and the nurses, from the doctors who come in and say, ma'am, you have that death disease. And the nurse that comes in and says, ma'am, did the doctor tell you what you had? Yes. Well, don't tell anybody you have that. So some of that stigma is being reinforced by the healthcare providers in these areas. Have you looked at what the challenges are with those?
I just want to say first, I think, the work that you've done, Steve, has been at the level of the tertiary care. Mm-hmm. But a lot of looking back at the narratives have been the journey to get there. Mm-hmm. You want to speak? That's probably what you're going to talk to.
Yeah. Yeah, so that's why Melissa and I looked at each other, because when we looked at our qualitative interviews with the patient survivors, so remember, these are folks, I designed that study intentionally to try to remove a lot of the confounders, and it's not going to be generalizable, but there are a few things to note about that population. Our patient survivors had successfully gone through whatever surmountable, whatever challenges were there, but they had overcome that, had been in treatment, completed treatment, were in remission. And they were asking them to look back about that experience and guide us through how they were interacting with each step of the process. And yes, there were some themes that were coming up about how the initial diagnosis, they were told, oh, this is nothing, that's just TB, right? Oh, this is an infection, take antibiotics. And how some of the data that we didn't get into is how patients were able to overcome either that level of provider-driven misinformation with resilience, or with a secondary source of information or support, either a caregiver or sometimes another healthcare provider. So from our tertiary level facility, a lot of the interview participants talked about how facilitation was through the healthcare providers who were telling them, oh, we've seen this lymphoma, it's highly treatable, you just need to take your medication and you'll be fine. And the patients were identifying counseling from healthcare providers at KCH as a facilitator to remain in treatment. So it's a double-edged sword. And I think additional work needs to be done on the differences that we could not observe in our population, and that is those patients who were either lost to follow-up, who never completed treatment, or those patients who are receiving the bulk of their care at a lower facility, and look at those experiences. But I'm guessing that you'll see a mixed bag. So for healthcare providers can be facilitators, but they can also be barriers. One thing I wanted to add on your comment about the Ghana scenario is that in Malawi, we were hearing that about the public radio shows, talk shows. They were saying a lot about, most of the interview participants are talking about what they hear on the radio is about cancer being a death sentence. And in fact, one of the identified opportunities was for a mass campaign to, and this is something that might be an area of focus for someone, is how you can engage with the talk shows, and everyone who has lived outside of the US, and even now in the US, talk shows are big. People get a lot of the information from there. So I think that's an avenue that can also be channeled to help with misinformation.
It was very interesting to look at this because I'm from a region, Central Asia, where TB is very prevalent, especially multi-drug resistant tuberculosis. And I was working in TB HIV programs, and actually my PhD was also on stigma and gender barriers. And when I was interviewing patients with TB and co-infection, I also have noticed that gender and stigma goes together, and stigma prevails more in females due to cultural and religious barriers. Like sometimes women can't go for diagnosis without husband, or she doesn't have support, she's looking after children and so on. So I was just wondering if you, in your data, you also looked at the gender, and if it's also prevails in cancer for females.
Yeah, I mean, we've talked about this. I mean, one of the challenges in looking at it in the qualitative data that we had is that the gender and cancer site are very correlated. So of course, our breast cancer patients, I think they were all female, correct? Lymphoma were more males than females. I mean, I would, so it was hard to kind of tease out like gender differences. I think what I would say is that there are unique issues, gender-related issues related to stigma. We certainly had more female participants who talked about dissolution of their relationships because of stigma, and so being additionally isolated. I don't know if we had any, I can't remember any male participants who talked about the same thing. And then their responsibilities were very different, but you know, what we found among men in particular is that loss of the economic role and the social role that was a very gendered role was also sort of highly stigmatized, and that resistance to being seen as like as weak or not contributing so that was a very gendered issue. When we are working in KS for this next phase, it will be a single cancer type. And we plan to look much more at the gendered experience of living with and how gender and stigma intersect. But thank you. I mean, I totally agree on an HIV, absolutely. We see such gender differences.
I have a couple of questions. One is in the anticipated grant or the new program, what challenges do you imagine there will be in recruiting peer navigators? And what do you think the role of we talked about the patient's journey from, how they actually got to the center to get care. What are you sort of the mediators of the quality of care that they got that will affect their willingness or ability to be a peer navigator?
You want to talk about the delivery of KS care in Malawi? Because I think that kind of speaks a little bit to that.
Yeah, so in Malawi, so KS, so there are two big cancer treatment facilities in Malawi. KCH is what I demonstrated is right in the center of the country, and it has the largest catchment population, that is central Malawi and northern Malawi. There's Blantyre, which is much south, and that's technically their business capital. So that captures a smaller section in the south. So most patients who need or who eventually get treated for cancer will be in those two cities. For KS, a big part of the treatment happens or has been incorporated within HIV treatment programs, as there's such a strong correlation between HIV and KS. And as Gita mentioned, part of treatment of KS is antiviral therapy for HIV. So in Lilongwe, where Kamuzu Central Hospital is, there's a non-governmental partner that's right next door. It's a kind of same compound, so to speak, that's called Lighthouse Trust, where all the bulk of HIV treatment happens there. And so they take care of Kaposi sarcoma treatment for those who also need chemotherapy. And so it's usually in IV chemotherapy that's given for about 6 months. So when we think about some of I'm going to quickly make a comment about the barriers to identifying peer navigators. One of the things that influenced this work, like we talked about, is the qualitative work, where actually it was the peers who were like, I am here, I just need someone to tell me. And if you need me to talk to patients, right? So there's that underlying willingness that we hope to leverage or build upon in this intervention study. And I think there will be several challenges. The biggest we've experienced in our treatment programs in Malawi is distance and cost for transportation. So what I didn't mention is that all those cohort studies, they are able to, while they are done under observational research study projects, but the basis of those projects is actually to build capacity for diagnosis, treatment, and follow-up of these cancers. So the funding has helped build that capacity, but there's been gaps in providing transportation support. Oftentimes we have to chip in and reimburse patients for transportation. So that might be a barrier in which patients are willing to be peer support navigators, and we have kind of addressed that in how we are proposing to train and to support them.
We have a question on the Zoom.
I think Catherine, please.
Yes. Yes. So
yes, go ahead.
Yeah, so I thought the comment about being on talk shows was important and interesting, because lymphatic filariasis, which has also been associated with a lot of stigma, both male and female, both for the hydroceles and the leg manifestations, which are clearly obvious to everyone. Those have been problematic in all the places where they are endemic. And they've had a lot of success with the community approach, but also with talk shows and even, radio. So might be a model if you're looking for other successful models that have been used for many, many years. lymphatic filariasis is one that's been very, very effective and measurably effective, not just in sub-Saharan Africa, but also in India, Haiti, and Latin America.
Catherine. Thank you so much. And I'd like to thank all three of our speakers today because it's already 1 o'clock. The time has just run away from us. I'm sure we can talk a lot more about this topic. So if you can hang around, if you have a few minutes for folks to come, that'd be great.
Thank you.
And just to let you know that we have next month, the speaker will be our very own Dr. Daniel Long, who will be talking about his work on diarrheal illness across multiple continents, and is a phenomenal scientist that we have on faculty. And I just newly confirmed that in December, we'll have one of our chemical engineering faculty talking about development of sensors to diagnose, I think, tuberculosis and maybe even colorectal cancer. So a variety of interesting things. So to be seen. So please come join us in person if you can for all the online folks. Thanks so much.
Thanks for having us.